Well, I tell you, why don't we go ahead and get started? And I'm just going to through a couple of just introductory slides. First of all, thanks everybody for putting thoughtful comments in, um, taking the time to respond, to fill the surveys out. I actually read yesterday all the surveys from the last year, from the different town halls, the different themes, the different processes. Trying to understand kind of some of the common threads that you all are expressing. I think we just all have a great reverence for this mission, vision, and values, and I think that's a resounding positive, well-grounded, optimistic basis for all our work here. So it's just worth acknowledging that for a minute. Next slide. One of the things I think in reading through your comments and then talking to several of you is part of is understanding we're kind of looking at some of the same things from different lenses and different perspectives, and perhaps sometimes coming up with different interpretations or just different levels of observation. So, from my perspective, coming here in 2011, what was the essential question for our department that I sensed coming here, meeting with Dr. Raj, meeting with you all, talking with other people in the Chicago medical community and other, national healthcare leaders, what was the biggest, kind of fundamental issue from my perspective? I think it still animates what we do. Next slide. And I think it was for this department, this children's hospital, organizational survival as a credible, high quality, full service, public, financially sustainable children's hospital. And you can imagine each one of those words has a lot of weight. But I think survival is a challenge for all organizations. We know that most organizations, whether they be healthcare, corporate, often don't last a half century. We've lasted a century. So it's a constant adaptation. But I saw and still see several existential threats to the survival of the organization. And I think you can even think back on the last few months as we've kind of seen what's happened in Chicago. We've had multiple children's programs close. The entire children's hospital in Rockford closed in 30 days. We've seen hospitals essentially merge with much larger organizations, be subsumed by them. We've seen programs be dismantled. And this is related to a lot of intense market forces throughout Illinois and the United States. So you can imagine that all those things are and continue to be, possible outcomes for our program that depend on our excellent stewardship for good outcomes. Next slide. So we developed a strategic plan in 2016, really in response to the concerns of the university, really around all those things, wanting a viable, sustainable program that met the missions and needs of the organization. Next slide. And I think there are probably three main, there are many things that have been done by this faculty, but I think if I were to roll them up in the clinical space, it's actually getting into U.S. News and World Report as a scored entity, which took really 4 years. It's a 450-page document, enormous effort by all programs, and it had to do with building out programs that sometimes we didn't have fully developed. Then actually recording and tracking data and getting to the point that we're actually, if you depending on count, we're like almost a third organization in Illinois. And we're really in the top quartile of all children's health programs. And that's an externally verifiable entity. And there's other ways you could look at this, the Vermont Oxford, but this is a substantial placement of us as a credible, sustainable healthcare organization in Chicago and the region. Next slide. The next was really just moving it up this NIH funding hierarchy, which is the most recognized one, the Blue Ridge, going from 66 as far as 35, getting us clearly into the top quartile of American medical schools in terms of research portfolio. And we did fall down a little bit this year, but we've had tremendous activity by multiple investigators to bring in, I think at this point, 4 new R01s this year. Those are the main NIH grants. Next slide. And I think in the education programs have flourished. We now have tenure, kind of permanent accreditation versus 2 years in 2011. We have 5 fellowships versus actually 1 in 2010-11. We have a summer research program that's been going for about 7, 8 years. It's had more than 175 students. Our residency graduates moved on to excellent positions, and philanthropy has really increased probably in the order of tenfold. So, I'm optimistic because of our mission and its grounding, and I'm optimistic because the work you've all done over 10 years to steer this organization to be credible, sustainable, well-grounded, and successful moving into the future. But those existential threats haven't gone away, and I think they undergird a lot of the concerns are really around how we're going to tackle those threats, what's the process and methods, and how we're going to go forward as a group. So I'm going to stop there, but I just wanted to put those in. There are other slides that kind of follow the topical areas. I'll send those out later, that you'll have a kind of a leave behind that's written, hopefully succinct, that's explanatory, and I'll turn it back over to Sindhu.
Thank you, Dr. Van Voorhees, for the presentation. And everybody, the objectives of this meeting mainly was to provide a safe platform for the faculty to voice their concerns and issues, a platform for the pediatric leadership to address these issues, and most importantly, to strengthen the relationship between the administration and the faculty. I want to thank everyone for your comments. Concerns relate to us via the survey. I want to thank Dr. Van Voorhees for addressing these concerns and for this meeting. And just to let everyone know, throughout the meeting, you can continue to send comments or questions on the chat box or anonymously to uicpedswellness@gmail.com. Jordan, next slide, please. Okay, so I want to start with the positive comments. So the great patient population and great faculty, commitment to the underserved, commitment to diverse mix of faculty and trainees, commitment to education and impeccable education leadership despite many challenges in volume, improved communication about meetings and upcoming events, more transparent follow-through on unanswered questions or problem areas. Next slide, please. Pediatric Summer Research Scholar Series is very good. The faculty continue to provide excellent healthcare to a largely disadvantaged and vulnerable population. They routinely see collaborations across all departments and divisions to appropriately diagnose and care for medically complex patients. Faculty continue to train and teach the next generation of healthcare providers by effective modeling and practicing what it is to be an excellent physician and healers. I appreciate the weekly pediatric updates, the frequent clinic updates, and the opportunity to have these town halls. The residency program leadership has adapted to address what were seemingly insurmountable challenges. They should be praised and thanked for their endless efforts to advocate for the residents. We continue to be a safety net for our patients, and our residents are fantastic through the pandemic. So before we start to the topic of discussions, Dr. Van Voorhees, would you like to add any more to the positive comments?
Yeah, no, I think that it's a testament to everyone's adaptability, quite frankly, courage to show up through the pandemic clinically in a very adverse and potentially dangerous environment pre-vaccine and do this work together, day in, day out. Problem solving, as everyone knows, just one thing after another, every single day to maintain the mission. It's really quite extraordinary, and I know I can convey that that's something that's very deeply respected by the dean, the CEO, the CMO, and particularly in the setting of a very constrained inpatient environment that was very complicated to shut down, then restart, and everyone recognizes this really has hamstrung and posed real challenges on just managing an optimal or even effective on a continuity-based clinical practice. So I think I'll probably pause there and just make sure we have time for everyone's voice to kind of flow through these comments.
Okay. So as we start the topic of discussions, I would like to comment that I will be reading all the comments verbatim, since some of the faculty are joining us by phone and cannot see the screen. I may be combining questions and comments if they are of the same theme. So starting with the first topic, we will be discussing changes in inpatient capacity, and under that, the clinical impact that this has had. This has been inadequate since March 2020. This has caused patients to be sent away, inward transfers refused, pressure to provide outpatient care when care should be provided with close monitoring in an inpatient unit. It looks like the inpatient capacity will be enough for the average census, but not for surges due to respiratory viruses. Very stressful to get patients admitted from clinic. The impression is we might increase to 24 beds shortly, but that will be impossible due to cohort needs and nurse staffing. I would much prefer if the department could give us an honest and realistic timeline for what we might expect instead.
So just, oh, I'm sorry, go ahead, Cindy.
No, Dr. Van Voorhees, we would now like your input on this.
So just a succinct statement. So when the construction of 33 War is done, we'll have 13 rooms, 24 beds. They're working to staff to 16. I haven't pinned Doreen down for the exact, but I would say that will probably take to sometime into August, okay? The average daily census pre-COVID was 12 by the hospital's measurement, 16 by our, I think, more complete measure of aggregation of all activity. As of July, we're tracking towards 100 admissions for this month out of, originally the 150 to 170 that we had. So we're getting back to nearly 2/3. It's exactly right. It's probably not sufficient to cover a surge capacity, or at least as much as we would like. We will have to look for alternative sources. This could be 5 Northwest. This could be pulling off the shelf the Shriners proposal, which is a good place, but untried and distant. Working with our newly developed partner, Cook County Hospital, potentially. We'll have to look at the different components within the system where we have capacity. The hospitals also expressed flexibility that if there is a dramatic surge in viral illness, even COVID-19, they'll readdress bed allocation. So I think there's several options.
Thank you. The next is the lack of ability to admit COVID patients.
I wonder, I'm sorry, Sindhu, I wonder if it makes sense to read all of the questions under inpatient capacity, because I know a lot of them are somewhat repetitive, rather than to do each one, because I know there are many sections and we wanted to have time for people to also have discussion.
The first ones that we just read out were clinic related, and now the next set of comments were education related. So these are, it has a huge effect on education, residents, and students. Residents are not getting a full inpatient experience and are frustrated. I'm concerned that the decrease will spell doom for our residency program. The residents are not adequately trained for such volume. And the last was the subspecialty related. So subspecialists cannot keep up with your skills when the volume is low. Decreased consults impacts reputation. And if our subspecialists are unable to admit their patients, they will likely eventually seek employment elsewhere.
Well, I think the two questions are about clinical activity sufficiency at the trainee level and the subspecialist level. I think they're important questions. On the trainee level, we are using resources made available by the dean's office to place our residents in outside rotations, for which they're in significant demand for them, actually, because they're excellent residents, to make sure they meet their ABP requirements. So no one's going to not meet their ABP requirements. They may have lagged a year, but they will complete them before they're done. We certainly hope we'll rebuild the indigenous capacity, but in the meantime, that's what we're doing. For the subspecialist, this, I think, brings up the importance of really trying to aggregate more volume through partnerships. Specifically, in the partnership that's proposed with Cook County, several of the specialties will merge their call schedules together. So when you cover at our unit, our hospital, you'd also cover at Cook County. This will do two things. They'll give you more activity during that inpatient time, hopefully while we're rebuilding volume here, but also additional activity at Cook County, also a low volume activity place. And then second, it will allow one to also do more outpatient clinics. A third proposal out there is to have a PSA with Shriners for them to use their subspecialists for coverage so they can attain American College of Surgeons certification. So the possibility exists that we'll aggregate through this distributed model or affiliation model maybe 2 or even 3 hospitals that will provide subspecialty coverage for, either through telemedicine or direct contact. And then we'll also be able to increase faculty's ambulatory exposure and clinical activity, which could also potentially support better incomes for them as well.
Okay, thank you. And just to go back on the previous slide, Jordan, Dr. Van Voorhees, if you could please address the lack of ability to admit COVID patients.
Yeah. Oh, yeah. Sorry. Yeah. So right now, I think we have one PICU bed that's and one med surge bed or step down bed. It's not. I think it's very suboptimal. It lagged for a long time. It's very problematic. We're working to grow that. I think that along with security on the unit are probably the two next major issues, along with educational workspace, teaching space.
Thank you, Dr. Van Voorhees.
So I realize that sounded vague. The reason it sounds vague is because we have to work with the hospital to get these things done. And right now we're working on the security issues and on getting educational space returned. I think returning to the issue of COVID bed utilization or availability. Also, it's particularly if we find we really use those two beds or they're just not available, then that will go up the priority list of negotiations with them.
Okay, thank you. Jordan, next slide. Yes, so this is inpatient capacity, but governance related. Who is representing pediatrics with a hospital if the hospital says we should be preparing for pediatric surges? And what resources are the hospital going to provide us?
So, it steps into a little bit, I think, of how we relate to the hospital and how the hospital relates to us. So the succinct answer is multiple peers, including myself, have interactions with all levels of the hospital to get things done. And we have stood up some good working groups, including the early morning working group that does do a lot of problem solving with Doreen and Lori, regular meetings between myself and Terry Vandenhoek and Shelley Major. I don't think exactly, and I could go on and on with Andrew Kreppel, Jay Schreier, other individuals, Dr. Pillars is very heavily involved, Dr. Agi Ragavan. There are multiple individuals. Around the space issues, it is probably primarily myself, Jay, and Andrew interacting with these different levels. What we are missing is a service line model which would easily integrate all these perspectives and systematize the input and the sense of access to the hospital decision-making process. That has been advocated by the department for at least 3 years, verbally promised, but not yet instantiated. So we're looking at kind of how to streamline that input so that it's really, it's not so many touch points to get something done.
Okay. Thank you. This is very important. So we will follow this as a part of the wellness committee also. And the next slide, please. So professional fund modification. It is very frustrating that this was conveyed to us in a random email from administration. My academic productivity has already suffered significantly due to all the new and increasing demands placed on me during the pandemic from work. Not being able to attend conferences due to this decrease in addition to our pay cuts is an extra hit to my personal academic advancement. $1,000 a year for 1.0 FTE is down 150% from previous and does not allow funding to attend conferences at which we may be presenting. We need to have travel support to conferences and a CME fund that supports this. The decrease is not conducive to academic work. Dr. Van Voorhees, please provide your input.
The issue is, how do we have a budget that we can live within, ideally without laying people off, or as much as possible avoiding that, fulfill the mission, and build, I would call economic momentum to improve this situation. I don't think this is a good situation. I don't disagree with the comments that are made there. The motive engine to fix this is going to need to be the placement of the physician workforce, to the extent that they swing between in and outpatient, is more in outpatient where they can generate more revenue, and less in inpatient where it's relatively more difficult to generate revenue. It's been difficult to do this because so many of our sections are 2 or 3 person sections. And it's very difficult to cover call like that. Off basically what I call port and starboard from Navy days, one day on, one day off, and still have as active a clinical practice as would be optimal. As we integrate some of the call schedules with colleagues at Cook County, we will be able to improve physician lifestyle and place them more in outpatient clinics and generate more revenue and improve the financial status of the department. And just without no budget is coming later, I'm going to just pause there and say that's not the whole picture of how we'll solve our budget, but it is part of the internal picture.
Thank you, Dr. Van Voorhees, for acknowledging this, and we hope things change soon. The next slide, please, Jordan. So this is salary withhold. The first topic, we have subtopic would be regarding to the withhold. So please explain what is happening with the withhold. I am confused if that 10% is being continued or transferred to an incentive performance plan. Can you explain why are we not going back to our base salaries? This has been confusing from the beginning. The limitations on the inpatient services and the inability to grow any program has caused huge harm to the faculty's ability to earn back the withhold. It appears to be a no-win situation for the Department of Peds faculty. Can the College of Medicine tell us the plan for the withhold going forward? Dr. Van Voorhees, please.
Yeah. Thank you. So the 10% withhold is the same structure that we had last year. It applies to monies other than essentially external contracts or research contracts, or if one's working for the dean's office, for example. So it's not a new 10%. It's the same one. It is more impactful because instead of being applied for 9 months of the year, it's going to be applied for 10 months of the year. It is not specific to pediatrics. It will be applied across the College of Medicine. The original budget that we submitted to the College of Medicine in May did not include a withhold. That budget was rejected. We added back in the withhold, or put a withhold in along with multiple other cost-saving approaches, with the premise that we did not want to, with the exception of one individual, issue notices of non-reappointment. As far as getting the money back, so to speak, we're working to establish the baseline. The baseline is the RVU productivity that we projected in the current budget, which is essentially almost exactly the RVU productivity of the department in the last 3 to 4 months. So it's not an overly optimistic projection. As I see this working functionally, financially, we will set a goal that will be something around, this is conjectural, where we were pre-pandemic, maybe adjusted, we'll see, or against some national standard, that at which point you would get, if you cross through all that RVU from, let's say, the baseline to this goal, you would get everything back. It obviously has to be work such that you'll get money back at a rate that it is meaningful for you. It also has to return money to the department to reduce the existent deficit. And I would say here is that no one expects the department to, on its own, solely resolve its deficit, but it does expect us to shift the provider model in such a way that will give our physicians a chance to potentially produce more RVUs. I hate to use that word, earn more income, and support better salaries for them. One possibility is that, as for example, say we combined into a 4-doctor call schedule with Cook County. Potentially, those physicians could add 1 or 2 clinics within even the existent CFTE policy. Assuming that we could gradually get them patients, they would substantially move their RVU productivity beyond the baseline. So this is where the college, the department, and the individual's financial incentives would ideally, if at all possible, align.
Thank you for the answer. Just a follow-up question. Is there a tentative timeline to set the goal?
The goal would probably, the timeline to set the goal would probably be in the next 30 days before we start the August, before we hit the new appointment year on August 15th. I know that there was some commentary I think I read earlier about, delays in finding out and confusion. And just to say that last year, the college, I think, didn't really announce it till September, well into the year. It took at least a month to a month and a half to even get a proposal from the Department of Finance approved by the College of Medicine. And then subsequently, we had to actually complete the analyses. So I'm sure it's probably true. You may not have seen some of your RVUs for that second quarter until well into December. However, it was not almost impossible, given the timeline of implementation and the approval process, to have delivered it to you sooner than that. So just to explain what was that lag, I agree this year we would want to outperform that.
Thank you. Next slide, please. So this is RVU related. I have met my individual RVU goals, but have pay withheld due to the department failing to meet metrics. This is very frustrating while concomitantly being asked to work more clinically. The withhold is not proportional to the work being done by various sections. Continuing the withhold is not consistent with the rest of the university. The withhold should not be related to existing department debt. It's very frustrating that the withhold is communicated to us a whole quarter later. So by the time we have the information, we can't do anything about the next quarter because it has already passed. How can we see how we are doing on our RVUs during the quarter? RVU generation verification should be provided. We should be seeing the raw numbers data from WWT and how it is then put into the withhold payback formula.
No, I think there's some important I'm trying to just capture, because there's some process elements there, but I'm going to try to just tackle some of the more conceptual ones first. The policy that we developed was first discussed, within the executive council. It was discussed at the chiefs, and then it was compiled together as a consensus. Basically, I think there was actually a vote at one point about whether whether it would be, half department, half not, how we would allocate the 6% discount. And then that policy went to the advisory committee. And after it was, essentially agreed to by the advisory committee, and after it had been through that entire discussion cycle, it went to the dean's office. So one important thing to realize there is that process that gives a sense of, proper participation takes time, takes a lot of meetings, and it delays things being done. Doesn't mean we shouldn't do that, but I think it's important for you to realize some of the things that you want to have done actually compete with each other functionally. We're working to sort of balance those needs. Some people in the department wanted to have a department level return, and some did not. Some people would never have received anything if there hadn't been a department return, and some people saw their return limited by the fact the department return was maybe less than what they were going to have. I think you need to realize that your peers often have differing opinions on this topic because your financial interests may vary, and you may or may not express them to each other, but you certainly express them to us. So we work to try to reconcile that in the most just way we can. I think this gets into the forward-looking, how do we get those goals out there really early, and then how will people see them? I'm going to ask, and if Christine's on the phone, if she has any ideas of how we can, capture or return this information more quickly to faculty so they can make adjustments.
I think the faculty, and Harsha can comment on this as well, have access to their own RVU data, and I believe we previously provided them with that information, and I'm happy to re-forward that information as well.
This is something where we may need like a teach-in with the chiefs so they can help their faculty, or maybe one resource person that can assist people. The second is, other ways that you could tackle this. We can assist you in adding a clinic. We're another site we've almost got approval for that will have spots. Friday afternoon still has some spots. Assuming that we can put patients into your clinic, which I would say is hopeful, at least at some level, that's going to increase encounters and increase RVUs. So you can use proxies like total number of patients seen, maybe in comparison to the previous year, or just the actually adding yourself into as a kind of, I hate to use the word resource or a spot. The 6 years I spent in community practice where we were paid based on what we produced, I extremely carefully watched on a daily basis the visits, the level of service, each bill that went out, each procedure that was done, and monitored that on a weekly, daily basis and reviewed that. And I think that's probably what many of you want to do, is something like that. But we didn't always, these were in some ways, visit numbers were really more proxies. So we'll help you, but there are other things you can do even yourself to begin to kind of capture where you are vis-a-vis maybe a putative performance standard.
Hi, Ben and all, this is Deanne. I just want to say that I've looked for that RVU data on Epic and I can't find it, but we should be sure that people get this regardless, because that's a good quality check to make sure that everything of their activities is actually being billed. And I know in my reviews for neonatology, that was how I found a lot of things that they were opting not to bill on our behalf. So I think there's multiple benefits to having that RVU verification.
So, Deanne, I think that's an excellent point. This is Harsha. What we are doing right now is that Jordan Henry, every month on the last Friday of the month, is sending all the division related metrics at an individual level, which has the individual RVUs chart for that month. But I agree that we need to come up with a system where every individual provider receives it every month, and we will send out an email with all the screenshots and the direction on where you can find your own RVUs, where you can choose the time period. The only caveat is that sometimes they're not really real time, though it should be, but it should give you a close idea about what's happening. So we will send that out, and we will work on maybe considering an individual email to each provider so that it doesn't have to be an active process of logging into Epic. We will take this back and discuss. Thank you.
Thank you. Moving on to the next question. We have an anonymous question from the chat box. It is my understanding that the withhold is not happening this coming year for the Department of Medicine. Could you comment on the discrepancy in salary withhold?
I'm not aware of that. I couldn't speak for medicine, but my understanding from the dean's office is that it is going to be applied to all departments. But that could be. I guess that could be true, but that's actually not my understanding. Not my understanding.
Thank you. Another comment, again anonymous. The pediatric department was the only department who lost inpatient beds. How can the inpatient metrics even be applied when the decrease in inpatient beds and the staffing for inpatient unit cannot support the metric goals?
We did receive a discount last year for this unit. Now the question is, would we use that this coming year, and how would we apply it, since this could be an ongoing or year-over-year, impact. I think that we have to look at what I would call an adjusted baseline. In other words, if we're space constrained, realistically, to some extent, still, particularly for peak census, how do we adjust the goals of the faculty members who are most impacted by that? I think that's how I would say, yeah, to be just, it has to reflect the structural limitations that exist.
Thank you. And we have another comment from Dr. Keenan. If you're at or above 100% working, additional clinics will not make a difference.
So one of the things that I think we'll need to do when we create this model will be to account for people that actually exceed the goal with some level of return. So in other words, it possibly exists that you could earn dollars or monies in excess even of your salary. Once you get to 100%, that you go over that. Now, the one complexity of that is we've also been trying to stand up a process to compensate people for extra hours worked. So in other words, people that volunteer to work extra hours and recognize that beyond their clinical expectation will have to resolve. In other words, we can't pay people twice. In other words, if you generated more RVUs because you worked 10 extra clinics, and you got paid for that, maybe we'd have to adjust your goal for that. I mean, there's some nuances and complexity we're gonna have to think about, but I would just say that we want to make sure that additional effort is financially recognized one way or another, and we'll have to work on that as a group, as a multi-specialty group.
Okay, thank you. Jordan, next slide, please. If our pay cuts and this withhold are incentivizing us to see more patients, should I not spend my time teaching the students? Where is the compensation for all the time I spend teaching in my full day of clinic? Teaching seems to be penalized right now. The students pay a lot and they deserve better.
Yeah, I think that's an incredible. I get you. Yeah, you had, I think, on number 4 there. So did you want to read that? I'm sorry.
No, that's different.
Okay, different. Okay, good. Okay, excuse me. Okay, so I think it's a really profound argument, and I've raised it multiple times in the chairs meeting. In some ways, the college is rationalizing payment models around clinical care without rationalizing payment around education. And I think that is truly problematic. I believe we're underpaid as a department for the amount of educational activities we do. I've made that case to all the 3 deans I've worked for, to Mr. Van Neck repeatedly. I'm actually in the planning group around administration for the strategic planning group for the college. I've advocated for it there. I believe they will tackle this. They have not tackled it yet. I think this is an actual danger that we're going to have to think about ourselves. There may be things we can do at the department level in terms of how we use the state dollars to reallocate those around, to some extent, an educational RVU model. So I think that's a really good comment.
Thank you, Dr. Van Voorhees. And the last question, is there a possibility that the faculty will be laid off in the next 1 to 2 years?
There's always a possibility of organizational failure. I mean, that in a capitalist free market system, even with a state entity, the state entity can decide it does not want to be in that business activity. That's why it's essential to work together on the facilities, the planning, the clinical delivery model, and the budget to continue the progress we've made. There are no plans right now for such an event, but if we were unable to manage our budget within the expectations of the college, that could happen.
Okay, thank you. Next slide, please. So communication. The communication is redundant and unclear and not helpful. The communication from the hospital that the department didn't know about shows how little PEDS is valued. When we ask questions, we are met with a defensive posture that many of us feel as though our jobs are at risk if we ask questions and try to stand up for ourselves and our patients. I was disappointed that we found out about the adult service taking over 5 West from the hospital and not from our leadership. Next slide, please. The Department of Pediatrics leadership is severely out of touch with the faculty. Despite the enormous amount of feedback given from the faculty to the leadership from the town hall meetings, which largely centered on the issue of poor communication, the connection has deteriorated further. Leaders are not willing to have an open dialogue. There is a severe lack of transparency. open discourse and an honest exchange of ideas is desperately needed. We also need leadership to be more aggressively advocate for our needs, how we are essential to the mission of UI Health, and we need more awareness of the impact the changes have and need to hear a very specific plan with a timeline of how we will be improving going forward. Dr. Van Voorhis, please provide your input.
Yeah, so thank you. I think these comments have been made. I think, actually very broadly in several forums, including the Chiefs meeting this week. Just to briefly restate, the process that we have in place is the process that exists within our bylaws, and they're open for change or adjudication, in the sense that we have a chiefs group and an associate head group. We meet either every 2 weeks or every month. We're open to dialogue. Many chiefs do not speak. Several do. I would love if we had more chiefs speaking, and I think they could, aggregate a lot of your concerns and add to the discussion. We have an advisory committee that meets every month now that I try to meet with at least every 2 months and go over some of the main issues. For example, the PAVCC, or an early version of the Strozier-Cook County proposal was shared, at least in aggregate, with them to kind of vet basic core issues around that. So I understand that some individuals feel that there's no transparency. I believe that actually work really hard to embrace all these settings, hear people out, respond as best we can, tackle the problems together. We need people to speak up a little bit more in the Chiefs meeting, and look forward to more participation. I mean, I think that more participation is a good thing. I think another challenge we have is we have quite a few meetings in our department, actually a lot of meetings and a lot of emails around really actually trying to collaborate together. I think maybe those meetings and that email system isn't always working for us. So maybe we need to maybe less is more. Maybe we need to kind of reevaluate our kind of internal communication process. In terms of the issue of transparency, there's really 3 basic categories of information. There are major financial, strategic, tactical decisions at institutional level made by the vice chancellor, the dean, the CMO, which are shared variably with heads depending on a need-to-know basis, often late in the process. If they're shared before before they are comfortable disseminating it, those are held in confidence. If you share those things outside of that, then you broke confidence and they will not share with you again. And this has actually happened to me. This is feedback I have received from the dean and from the CEO that I overshare information with my faculty, and it causes problems for them. So you see, it kind of cuts both ways. So that's one category. Another category is departmental information that relates to budgets, salaries, personnel, and HR. 85% of the budget is more or less is salary. So you can see that a lot of things quickly get into HR and personal salary information, budgetary information that we cannot share. It may not even be ostensibly a salary topic, but it touches on that. We have to retain the confidence of maintaining that material. And the third category is the things where we try to work to discuss major propositions, ideas, things that we can actually implement, change, and do ourselves, to be problem solvers together. And those all go through that process that I described. There's no major policy initiative that doesn't go through that process. And so I would advocate that the chiefs, the advisory committee, begin more extensively sharing their conversations at their meetings, which they should be having with you on a monthly basis, about what they're talking about with us. And then I think we can have a better discourse.
Thank you, Dr. Van Voorhis. We have a comment from Dr. Pillars. Who are the members of the advisory committee?
The advisory committee is an elected body. And if Dr. Hooper's on, but Dr. Hooper could name all the members. I believe Dr. Osta is on that committee. I believe Dr. Boucher-Berry is on that committee. I think there are actually, I think 4 or 5 or 6 members.
Yeah, let me just mention who's on the committee. Aside from myself, it's Saba, Karen Hayani, Louis Sue, Michelle Barnes, and Claudia Bushaberry.
Yeah, so maybe it's a good moment for you to kind of share with the faculty, Dr. Hooper, kind of how the committee works and how somewhat the activities are, and maybe how faculty can hear from you, or if they want to hear from you, what's being discussed in the committee, and how that maybe can be disseminated. That process, that's another influential pathway for faculty.
Yeah. So the committee is an advisory committee. We're given tasks by the department head, by Ben, or whoever he directs us to, and then we discuss what needs to be discussed. CFT, other things. I guess going forward, we could perhaps put something together as a summary for the faculty generally. But again, we serve as an advisory group to the department head.
Thank you.
Thank you, Dr. Hupert. I think a summary from them is an excellent thing. Next slide, please. So the next topic is the budget deficit. What caused the increased deficit in our budget? Please be specific on the primary reason that in 1 year, pediatric budget deficit exploded over $3 million. Is the department reducing those areas specifically that contributed the most to the deficit?
Thank you. Yeah, good question. The most problematic year we had with our deficit, the one that's really anomalous, was 2019. And a very simple heuristic is it's a year in which many of the hires that we made to flesh out the clinical program, particularly clinical leadership of the clinical program, really impacted us in full force. Remember, fiscal year 2019 starts in 2018, goes to 2019. So that's one important thing. We grew the program in very specific ways, and I think it recruited some absolutely outstanding clinician leaders and research leaders. Analysis of that, the analysis that year revealed several sections had worsening financial performance, and I'm not going to be able to name them all exactly, but I'll say one was general pediatrics, another one was neurology, and there are actually 2 others. They each had very specific issues, sometimes with transitions in faculty, adjustments in their call schedules. It's probably more neurology. In general pediatrics, there was a specific impetus to expand after hours and during normal hour availability. We did have an increase in patient volume, but not sufficient to keep pace with the increased costs. That was an attempt to kind of grow the primary care base. So that explains a substantial portion of it. I'm probably going to I can't remember the other 2 sections, and I think if I'm going to get too far into it, we're going to start beginning almost sound like we're getting into people's salaries or cost structure and I think that's probably not the wisest thing to do. The other thing that happened that year was there were some contractual costs from the previous year that were not paid that ended up being dropped into 2019, kind of exaggerating. And there were a couple of things like that where, bills were paid late and then paid that year. So it's kind of an aggregation of several things. What happened in this most recent fiscal year where things performed better, and they're performing even better this year, is that we really reversed some of the changes that we had made in those sections that drove the budget deficit, and that's led to an improving financial picture. We also substantially downsized the administrative group by about 25%. and made other adjustments. But those are the main things. We changed the way some of those 4 sections ran. We downsized administration and looked for other cost-cutting opportunities. Make sure I covered all that. The deficit so the deficit went to almost 6 million from a baseline of about 1.5 million to 2 million, and then it would drop down to 3.9 million last year. Great work by Dr. Kumar and Ms. Miller, and it looks like it'll drop close to 3 million this year, and then we are hoping to get it below 3 million next year, if not further down, but we'll see.
Thank you, Dr. Van.
Dr. Vivi, this is Harsha. I also would like to add that that particular year and many years, our ACR payments get paid many years after the service is provided, because that's how Medicaid managed care works, unfortunately. So that also led to a massive deficit.
Yeah, I think what Harsha is getting at there is that they didn't pay us, so the revenues really dropped. So it was like kind of like we laid out all these staffing plans, and then part of it wasn't that it was that we actually did see more patients, but then we were not paid. And so really that 6 million is really, if you really look at it, it's probably more like 4 to 5. Maybe related to some of those costs, and the other piece of that is really, you might say like sort of artifactual fluctuation due to just where things landed. Revenues going to other years, expenses landing on that year.
Okay, thank you, Dr. Van Voorhees and Harsha. Jordan, next slide, please. So these are general comments. What happened to philanthropic fundraising? Dr. Van Voorhees.
So we, Mary Johnson resigned 1.5 years ago. We've not been able to replace that position. We are still working with the advancement office, which also itself has had some staffing issues, to, I would say, do as many of the basics as we can. Ann Lindner is very helpful. Khadija Ahmed is very helpful. And we're maintaining a lot of the reach out to the donor base, like the annual report, other updates, to maintain the relationships. And then, of course, we're working also in the area of foundation support. The actual number of it's a total fundraising, at least as of last year, continued to increase. I think it will again this year, because we did get one $500,000 donation that funded in whole an endowed professorship that we're anticipating the placement of that endowed person probably later, early in the winter. So it was actually a successful year in terms of fundraising, and we're continuing to work with some of these large donors on other potential donations, and I think that will grow. We have asked the college to support an on-site philanthropy person to help us. They have declined to do that. I'm hopeful that with the advancement office of restaffing, that looks like they've got some really organized people, that we will be able to gain more traction.
Thank you. There is a shrinking number of providers in the GenPeds division, yet a seemingly expanding number of clinics that need to be filled. What is the plan for doing so?
Yeah, this is a challenge. It relates to the problem that developed in 2019 when we expanded access, but we didn't really have a commensurate increase in number of patients. So we're trying to find the right balance between the availability of the physician, to do the work, the number of clinics that can be opened, the demand by patients that are there. One of the things that we really observed when we really expanded access was that we actually had a diminution in census in the resident clinics, which was both an educational problem and a financial problem. So we're really trying to find that right balance between having enough off-hours access that we support our patient population, but not so much that we dilute out our resident clinics.
Okay, and we have 2 minutes left, and this is the last question. We request details about realistic expectations about nurse hiring.
Yes. I believe there's one nurse in hiring in process in the CYC. We're very budgetarily constrained, and I realize that seems like shooting your foot to you know, in the process of trying to run a foot race, but you know, to avoid you know more draconian things, we've had to sort of cost constrain everything back to where we were last year. We anticipate as the CYC gets busier, we'll be able to gradually improve the staffing, and that I think they may be talking about nurse hiring in the unit.
I think there's also the inpatient unit
Yeah, that's right.
staffing issue, which
Yeah.
comes up. Yeah.
Yeah, actually, yeah. Doreen told me today that they are in the process of hiring to staff out for 16. I don't know whether in her mind that means 14 full-time people and then 2 staffed episodically with the agency nurses. But I understood from her is that they're actually trying to hire nurses to staff for 16 beds.
Thank you. Next slide, please, Janet. So these are some of the ideas put forward by the faculty in the survey for improvement. Strategic partnerships, higher profile pediatrics foundation, frank discussion about the future, increased capacity for outpatient observation status and infusion. UIH and College of Medicine need to make a strong public detailed commitment to child health, requesting to increase seed funding support for basic and translational research to get more NIH funding. Focus effort on confirming appointments better or get individualized feedback about billing. Being stricter with our late show and or no-show policies with some negative consequences, and that would decrease the number of no-shows or late shows.
Thank you. Those are great suggestions, and I think we'll want to assimilate those. I think I'm gonna tackle the sugarcoating, which I've really enjoyed. Your observations of me in my manner of setting up problems or solutions. And first, I want to say that I'm very interested in the details of problem solving and the problems that you're facing, whether they be educational, research, or clinical. And I think those of you that work closely with me have noticed, I think I ask a lot of detail. I'm very focused on how problematic something is. I'm also very focused on what's the upside, the opportunity, the possibility buried in that problem that we can transmute into something that will work for us, either just to solve the problem or maybe there's an opportunity. And it's a bias born out of the great mission we have. It's a bias born out of the experience of the last 10 years of just seeing a tremendous amount of bootstrapping up. And it's born out of a realistic perspective on clinical practice that in working with patients and families that you have to have an optimistic blush to help people progress. So I hear the concern of sugarcoating, and I'm going to be very much on guard for what appears to be doing that. I've tried to be as more direct and sort of set some kind of more baseline expectations that maybe feel like they're more on firm ground. But if I'm giving you an optimistic view, it's because I actually believe it can be achieved. And I don't set goals for us that I don't think are realistic or that we can not tackle together over time.
Thank you very much for everything, Dr. Van Voorhees. We've come to the end at 6:02. Thank you, everyone, for participating in this town hall meeting. Please continue to send comments or questions to the Faculty Wellness Committee. Goodbye and good evening.
Sindhu, can you show the list of the Wellness Committee?
Thank you, Sindhu.
Go to the next slide,
Thank you
please.
to the whole committee for
Huge
for all of the hard work that you're putting into trying to help us all do better.
Thank you all. Have a good evening.
Thank you.
Thank you.